education, quality, and safety. Before I pass it over to today's presenter, just a couple of quick housekeeping items. Within your GoToWebinar control panel, you'll find a handout containing the accreditation for today's activity, including the relevant disclosures and objectives, and the brief biography for today's speaker. Following the presentation, we'll have a question and answer session moderated by Dr. Reese Clark, Senior Vice President for Clinical Research, Quality, and Education at Pediatrix Medical Group. Please feel free to submit your questions at any point during this webinar using the questions pane found within your GoToWebinar control panel. Within 24 hours of the conclusion of today's session, you'll receive an email with instructions on how to complete the activity evaluation and how to access your CE certificate from within the Pediatrix Continuing Education portal. Please feel free to email the Continuing Education team if you have any questions at continuing.education@pediatrix.com. We're delighted to have Dr. Andy Combs join us for today's Grand Rounds webinar. Dr. Combs is a maternal fetal medicine specialist and senior advisor for MFM clinical quality for the Pediatrix Medical Group. As mentioned, his biography can be found within the handout section within your GoToWebinar control panel. So without further delay, I'll pass the virtual mic over to Dr. Combs to kick off today's session.
On antibiotic stewardship concepts and the implications for both maternal and neonatal care. I have no conflicts of interest in this topic, and I will not be discussing any off-label use of medications. The genesis of this talk has to do with certain quality gaps that the CDC has pointed out. One is that more than half of the antibiotics used in hospitals today for certain specified conditions is not following recommended guidelines. And the CDC also points out that antibiotic-resistant organisms in the USA today are now causing almost 3 million infections annually and over 35,000 deaths. The objectives for the talk will include that the attendees will be able to list the 6 Ds of antibiotic stewardship, and also discuss the rationale behind doing penicillin allergy testing by skin testing for patients who report penicillin allergy, an important concept of antibiotic stewardship. We'll also discuss antibiotic use and how to optimize it for various pregnancy conditions. Let's start with a routine hypothetical case, but cases like this happen every day, and a simple question. So a young multiparous patient comes for a scheduled repeat cesarean delivery at 39 weeks of gestation, full term. She's not in labor. Just before placing the spinal block, the anesthesiologist says to the surgeon, well, do you want antibiotics? There's actually plenty of clinical trial evidence to answer this question. The role of prophylactic antibiotics in cesarean patients who are not in labor has been studied in several randomized clinical trials. A meta-analysis from 2014, almost 10 years ago, showed that the use of routine antibiotics substantially reduces the risk of wound infection by a relative risk of about 0.6, about a 1/3 reduction, and postpartum endometritis by more than half. So prophylactic antibiotics for cesarean patients, even those not in labor, has become routine. The American College of OBGYN recommends routine cesarean prophylaxis, whether or not the patient's in labor, by giving a single dose preoperatively. And the recommended regimen is a first-generation cephalosporin like cefazolin. And the cefazolin dosage, 1 gram IV if the patient is of relatively low body weight, less than 80 kilograms or 176 pounds, and a double dose if the patient is larger than that. The question comes up, if what's good for the goose, is it also good for the gander? If first-generation cephalosporins are good, wouldn't second-generation cephalosporins be great? The coverage for gram-positives and common gram-negatives like E. coli and Klebsiella, the both is the same, but second-generation cephalosporins have the added advantage of covering anaerobes like Bacteroides and other non-anaerobic infections. So wouldn't second-generation cephalosporins be a preferential use of prophylactic antibiotic? Well, this has also been studied in randomized trials comparing first generation versus second generation cephalosporins. And the reason why ACOG recommends a first generation cephalosporin like cefazolin is that the risk reduction related to the use of prophylactic antibiotics is similar with the two. So a relative risk of 0.38 for wound infection, whether or not first generation or second generation cephalosporin is used. Similarly, the rate of endometritis is also reduced by both, and although numerically it looks slightly advantageous to use a second generation cephalosporin, the reality is that these confidence intervals overlap, so it's not a significant advantage to giving the second generation cephalosporin. So ACOG gives preference to the first generation following some general principles of antibiotic prophylaxis. One is that you should use the narrowest effective spectrum antibiotic. The reason is if you give a broader spectrum antibiotic, eventually you're going to see resistance develop to that broader spectrum antibiotic. And we don't want resistance developing to our newer antibiotics because then they will become outdated and no longer be useful. You also want to use the lowest effective dose, and that's why ACOG says to use 1 gram for patients of reasonable body weight and a higher dose only if the patients are larger than that. And to use it for the shortest effective duration, which for C-section prophylaxis is 1 dose. But probably one of the more important principles in this whole scenario is that there's no reason why the anesthesiologist should be asking the surgeon, do you want antibiotics? Because everybody in the department having a repeat cesarean delivery or any cesarean delivery should be getting antibiotics, and the anesthesiologist shouldn't need to ask that. There should be a protocol in place at the hospital to standardize the use of antibiotics. Not only should antibiotics be given, but which antibiotics should be given. When you allow individual anesthesiologists and individual surgeons to willy-nilly modify and use the different agents according to their own preference, it creates confusion. And whenever there's variation in care, then patients don't know what's going on, the nurses don't know what's going on, the doctors don't know what's going on. There's always a possibility for error to happen because the expectation is not standardized. So a standard protocol is actually really important. So this concept of antibiotic resistance, using antibiotics eventually will lead to resistant organisms, is something that the CDC has been concerned about for decades. And every few years, they issue a periodic updated report in a monograph called Antibiotic Resistance Threats in the United States. The most recent report from the CDC is from 2019, and it outlines several threats of resistant organisms that are developing within the USA. One of the things that's pointed out in this monograph is that there are almost 3 million infections attributed to resistant organisms occurring annually in the United States, causing over 35,000 deaths. They also point out that Clostridium difficile, or C. diff, infections, which are antibiotic-related infections, as C. diff is a opportunistic superinfection that occurs when we wipe out the gut bacteria by using antibiotics, and C. diff then proliferates in the gut and causes this serious infection. Occurs in almost 250,000 patients annually in the United States and causes over 12,000 deaths. So overall, the load is antibiotic-related disease in the United States is over 3 million cases and almost 50,000 deaths annually. CDC lists 5 different bacterial organisms that are developing resistance to various agents. The ones in blue are the ones that are of particular relevance for OBGYNs and to a certain extent neonatologists as well. They also list an additional 8 organisms that are of serious concern. These 5 are urgent, and a couple mainly related to streptococci are of concerning classification. But CDC's concern about resistant organisms is only one thing that we need to consider in the perinatal space. And the other has to do with the infant gut microbiome. Normally, the infant is sterile inside the uterus. And so when it's born, the infant gut is also sterile. And within a matter of hours to days, the gut becomes colonized with bacteria and the infant develops a microbiome. And there's several factors that influence the development of that microbiome. One has to do with whether the mother is breastfeeding or formula feeding and what's going into the diet, any supplements or probiotics that are given. But antibiotics will alter the microbiome and lead to factors that may be disadvantageous for the newborn. So when we weigh the pros and cons of giving antibiotics to a mother during pregnancy, we have to look not only at the development of resistant organisms, but also the impact that it could have on the child or the infant. And there's several beneficial factors for giving antibiotics in pregnancy. One is obviously reducing maternal infection may improve maternal survival. And if the mother doesn't survive, of course, then there's going to be no newborn. So the actual treatment of the infection is critical and important. So we need to give antibiotics when they're indicated. But there's also some neonatal benefits to giving antibiotics, and that is several studies have shown reduction in early onset neonatal sepsis, primarily group B strep, reduction in necrotizing enterocolitis in a meta-analysis by almost 50% when the mother receives antibiotics during pregnancy, especially intrapartum. But there's also concerns about this dysbiosis, or the change in the nature of the gut microbiome. And this can persist for over a year and has been associated with some childhood autoimmune disorders such as asthma, atopic dermatitis, food allergy, and inflammatory bowel disease. So it's actually of some concern, and we have to weigh the pros and cons of giving antibiotics to pregnant women because of this potential impact on the newborn, which will last well into childhood. It may have lifelong implications. So this concept of antibiotic stewardship is something that's promoted by the CDC and other organizations. And it's essentially the effort to optimize the use of antibiotics to effectively treat, and I've added here in gray, or to actually prevent infection, because we talk about prophylactic antibiotics a lot during C-section, labor, and other situations in obstetrical care. Effectively treat infections, but also to prevent patients from the harms caused by giving unnecessary antibiotics and to prevent the development of resistant strains. CDC in this infogram points out, this is in their antibiotic stewardship monograph, that more than half of antibiotic prescribing for selected events in the hospital is not consistent with recommended prescribing practices. And they point out that almost 80% of patients treated for community-acquired pneumonia are not getting the appropriate antibiotics, and almost 80% of patients with UTIs are not getting the recommended antibiotics when they're hospitalized. A significant concern is the development of vancomycin resistance, because vancomycin is one of the few drugs that we have for treating methicillin-resistant Staph aureus. And so the overuse of vancomycin is something that we need to try to minimize. So the CDC recommends that every hospital have an antibiotic stewardship program in place, and it has a monograph that outlines the checklist for developing an antibiotic stewardship program. And that checklist is quite long, and it's probably more than the typical OBGYN or the typical pediatrician or neonatologist can be involved with. And it's actually recommended that the antibiotic stewardship program be run by the infection control department and infectious disease specialist in concert with the pharmacy. But it's important for OBGYNs and for perinatologists, neonatologists, and other pediatricians to be aware of and contribute to the antibiotic stewardship program, because the kinds of things that the typical infectious diseases specialist is going to be treating and making recommendations for may not always be in line with the current recommendations for pregnancy or newborn management. So it's important that we contribute to these programs as well and be aware of what's going on at the hospital-wide program. Joint Commission, effective this year, January of 2023, brought on some new requirements for antibiotic stewardship programs. So any Joint Commission accredited hospital hospital, which is over 80% of the hospitals in the US are Joint Commission accredited. And there's several elements of performance, including the idea that the hospital should allocate financial resources to the antibiotic stewardship program, that the program should be led by a qualified physician, usually an infectious disease expert or a pharmacist, but there needs to be a multidisciplinary committee. And this is the role for OBGYNs, perinatology, neonatology, et cetera, to be involved in this multidisciplinary action. There should be coordination, education, the hospital should be collecting data and should be taking action on any activities identified. The CDC summarizes these in what they call the 7 core elements, and very similar concept that the hospital needs to have a commitment to doing this, dedicate resources and dollars to it, that there should be a physician and pharmacist in charge of the program, that there should be interventions implemented, tracking, reporting, education, etc. So these 7 core elements are what's essentially outlined in the checklist that I showed you earlier. So when on the stewardship programs throughout the United States, you can see there's a huge amount of variation from state to state. And you can look here at your own state. Some states in the dark blue colors, California, we have a lot of our providers. In Florida, we have a lot of our providers. You can see they're dark blue, which means that over 90% of the hospitals in that state are meeting all 7 of the core elements of antibiotic stewardship. If you're in a state that's in a lighter color, then that means that there's room for improvement statewide. Your own hospital may have all 7 elements in place, but it's probably worthwhile for you to look into what exactly is your antibiotic stewardship program in the hospital, who's looking over things, and who's making sure that antibiotic use is appropriate within your hospital. This is a different sort of synopsis of antibiotic stewardship program, what they call the 6 Ds. And actually the reference cited only uses 5. I added the last one on here. The one is that you should always use the correct antibiotic. For example, on the C-section prophylaxis case that I showed you earlier, using a 1st generation rather than a 2nd generation cephalosporin is a good antibiotic stewardship concept. Make sure that you're giving the drug by the appropriate route of administration. Don't use oral antibiotics if intravenous antibiotics are needed, and vice versa. Use what's really evidence-based at the lowest effective dose for the shortest possible duration. And as information becomes available, for example, you may start a drug based on empiric signs and symptoms, and then tailor that drug as the culture comes back. You may now know that it's a gram-positive or a gram-negative organism and pick the antibiotic based on that. And then as the sensitivities come back, then you can de-escalate and tailor your treatment to the specific pathogen and the specific sensitivities involved. And finally, the concept that don't use antibiotics at all if it's a viral infection, or if there's not clear evidence that it's a bacterial infection, because then you're just going to help to select for resistant organisms. So a common example here is for treating rhinitis or the common cold. After 7 days, patients may have persistent symptoms, and there's a temptation to give antibiotics in that setting, but the evidence base suggests that that's no more beneficial than not giving antibiotics. So avoiding the use of antibiotics unless there's clear evidence of bacterial infection. So studies that have evaluated the overall benefits of having an antibiotic stewardship program in place at a hospital include that you can document that there's an increase in cure rates of infection and decreased treatment failures, fewer C. difficile infections, decreased adverse drug reactions, shorter length of stay, reduced costs, and of course less antibiotic resistance is the primary driver of having an antibiotic stewardship program in place. So specific to pregnancy care, it's important to recognize that reviews of medication use during pregnancy find that of the 20 most commonly prescribed medications in pregnancy, 10 of them are actually antibiotics, and an additional 3 are antifungal agents. So antibiotics are widely used during pregnancy. You can see here that nitrofurantoin, so 20%, more than a fifth of patients are getting this antibiotic, presumably for UTIs, but many other antibiotics are widely prescribed during pregnancy. And when you add them all up, I mean, clearly this is a widely used class of drugs during pregnancy. It's also important to recognize that not a single one of these antibiotics is FDA category 1, category A, which would mean that the demonstrated benefits far outweigh the demonstrated risks, and the risk level is incredibly low. So always there's a category B is the best category for antibiotics, meaning that there's no clear evidence of harm and some evidence of benefit. And some of these drugs are in the C and D categories, which really means we need to be a little circumspect about their use. Some of the concepts involved in antibiotic stewardship for pregnancy that I'm going to discuss today are prophylaxis for Caesarean, which kind of already started, prophylaxis during labor, management of preterm labor and preterm rupture of membranes, and group B strep prophylaxis. We'll also be talking about some concepts relevant to outpatient practice, including the treatment of one STD, gonorrhea, and the role of antibiotics in prevention of preterm birth and urinary tract colonization or infection. So prophylaxis for Caesarean, we had talked about for patients not in labor and showed that antibiotic prophylaxis was beneficial for them. It's been well recognized that patients in labor have higher risk of developing endometritis and wound infection, and so antibiotic prophylaxis clearly recommended for them. What's new as of 2016 was the idea that adding azithromycin in addition to the standard antibiotic prophylaxis was also beneficial. So this was a large multi-center randomized trial performed by the NICHD Maternal Fetal Medicine Units Network. What they did was they randomized patients to receiving either a standard antibiotic, and there was variation between these different centers. Some of them were using cefazolin, others were using second generation cephalosporins, others were using different regimens, but they were randomized to either receive the standard antibiotic plus a placebo, or they would get an additional 500 milligrams of IV azithromycin. These are patients primarily at term, although 10%, 11% of both groups were preterm. And what this study showed that adding this additional 500 milligrams of IV azithromycin substantially reduced the rate of postpartum endometritis, more than 50% reduction in wound infection. And so the overall composite measure was about a 50% reduction in infections overall. In terms of neonatal composite outcomes, infectious outcomes, as well as other outcomes, there was no difference. This is not necessarily surprising because the azithromycin is actually, although it started just before the skin incision is made, it actually takes an hour to do this infusion. So by the time most of the azithromycin got on board, these newborns were already born and they really had minimal exposure to the medication. So this has become more or less standard within the United States to add, in addition to using the first generation cephalosporin, which is recommended for all C-sections, if the patient is in labor or has ruptured membranes, to add the azithromycin. We don't add this for patients not in labor. Their risk of endometritis and wound infection is much lower than these untreated risks. And with the standard prophylaxis alone is generally used for them. So that's a current recommendation now to add the azithromycin. So the question is, what about patients just laboring in general? So these are not necessarily patients with group B strep, but just all laboring patients. And here there was a presented at SMFM early this year, was a large multi-center randomized clinical trial done in low and middle income countries throughout Asia, Africa, and Latin America. And these patients, because of just in general, have a higher risk of infection than in the United States. So they did this trial randomizing patients to receive azithromycin PO 2 grams during labor or to receive a placebo dose. So this is during the active phase of labor. And the composite primary outcome for mothers was a reduction in sepsis or death. And what they showed was a significant reduction in maternal sepsis, no difference in maternal death, although the rates here are very low. There was no statistically significant difference. Neonatal sepsis was comparable in both groups, and perinatal death no different between the two. So this received a lot of press. When they presented at SMFM, it became published in the New England Journal and got more press. The question is it relevant to the United States? These rates of maternal sepsis, 1 to 2%, are much higher than we see in the United States. And I don't think that it's become standard of care to use prophylactic azithromycin for laboring patients in the US. Maybe of value in the third world. But there was also simultaneously ongoing another 10-center randomized trial in Africa, Gambia and Burkina Faso. Same regimen, azithromycin 2 grams PO given to mothers in labor, and showed no statistically significant difference between the rates of maternal sepsis or neonatal sepsis in either group. The rates of neonatal sepsis were much lower in the other trial, almost 10%, here about 1%. The rates of maternal sepsis also lower, less than 1% in both groups. So what's interesting here is that this relative risk, although didn't reach statistical significance, is numerically almost identical as 0.65 in the other trial. So there may be a reduction in maternal sepsis from the use of azithromycin during labor in low and middle income countries, but it's the rates of these infections is much lower in the United States. Notice that in the other trial I said there was almost 10% rates of neonatal sepsis, here 1.3%. These rates are much higher than what we see in the United States. These are primarily term laboring patients, and these rates are 10 to 20 times higher than in the US. When we look at in the United States and North America, the rates of neonatal sepsis, this is from the NICHD Neonatal Research Network, depends on the gestational age, but at term, the rate of neonatal sepsis wasn't 0.1%, it was 0.06%. So much lower than in developing countries. The rate goes up with early preterm births, and in the very early preterm births, less than 28 weeks, almost 2% rates of neonatal sepsis. And numerically, the numbers of neonatal sepsis are actually, all these preterms add up to more than the terms. So neonatal sepsis is primarily a phenomenon of preterm birth in the United States. What we see in the NICUs in the United States is primarily going to be preterm patients. When you look at the microbiology of neonatal sepsis in the United States, it's primarily at term driven by group B strep and other gram-positive cocci. Almost 3/4 of the cases at term are group B strep in green or the gram-positive cocci in blue. Whereas in preterm cases, primarily driven by E. coli and other gram-negatives in gray here. So again, almost 3/4 of the cases due to these gram-negative organisms. So it's important to recognize that the treatment is going to depend on the gestational age because those are the common pathogens. Over time, as we've gotten more aggressive about prophylaxing for group B strep, you can see that since the early 2000s, the incidence of group B strep as a cause of neonatal sepsis dropped slightly, and the rise of E. coli has been increasing as a cause of neonatal sepsis, and as gram-negatives, other gram-negatives as a cause of neonatal sepsis have sort of risen progressively over time. So there has been a shift in the microbiology of neonatal sepsis, primarily driven, we think, by the use of group B strep prophylaxis. It's important to recognize too that there has antibiotic resistance is an important phenomenon developing in the treatment of early onset neonatal sepsis. Group B strep remains 100% sensitive to penicillin, ampicillin, and vancomycin, but there's about a 50% rate of resistance to erythromycin and clindamycin in recent series. E. coli most often resistant to ampicillin, but in recent series, about 10% resistant to gentamicin and overall 8% resistant to both amp and gent. So this antibiotic resistance is becoming a real problem for these common causes of early onset neonatal sepsis. So for management of preterm labor, so we've known for a long time that a percentage of patients in preterm labor, the infection in the intraamniotic space is actually the cause of preterm labor. And this is primarily occurs in early onset preterm labor. So this study was done where amniocentesis was done in preterm labor patients, looking at inflammatory markers and infection markers in the amniotic fluid in patients in preterm labor. This was a study from the Pediatrix Collaborative Network, our group, which found that the rate of infection, meaning the presence of bacteria or 16S ribosomal DNA, increased progressively with lower gestational ages and reached almost 20% as presumably the cause of the preterm labor in these early gestational ages, the less than 25 weeks. So the concept comes up, well, maybe giving antibiotics to patients in preterm labor would be beneficial. This concept has actually been debunked for over 20 years, primarily by the very large, over 6,000 patients in this Oracle 2 randomized trial. It's a multi-center randomized trial in Europe, comparing placebo to either erythromycin or amoxicillin clavulanic acid or augmentin, or the combination of the two together. And what they showed was that when you look at common outcomes like delivery within 7 days, no difference, NICU admission, no difference, respiratory distress, no difference, positive blood culture, no difference, and so death, no difference. So really no reduction in any adverse outcome by the use of prophylactic antibiotics for patients in preterm labor. So infection may cause a small percentage of preterm labor cases, but the use of antibiotics, at least these antibiotics, was not shown to be beneficial in the management of preterm labor. And then a 7-year follow-up study showed that any regimen that involved the use of erythromycin, whether alone or in combination with amoxicillin clavulanic acid, was actually associated with a slightly increased risk of functional impairment. So not only was the antibiotic use not beneficial for preterm labor patients, but it was it was actually shown to be potentially harmful. So for preterm prom, another study, the Oracle 1 trial, was a randomized trial comparing the same regimens, erythromycin or amoxicillin clavulanic acid, or the combination of the two, versus placebo for patients with ruptured membranes. And they showed also really very little benefit except for a slight reduction in the rate of positive blood cultures in the newborns. So culture-proven neonatal sepsis slightly reduced by the use of prophylactic erythromycin in this study. But the use of amoxicillin clavulanic acid, either alone or in combination with erythromycin, was shown to increase the risk of necrotizing enterocolitis. So this is the reason why we don't use amoxicillin clavulanic acid in patients with ruptured membranes, but there is some support for the idea that patients with ruptured membranes should receive some antibiotic prophylaxis. This study would suggest erythromycin. There was a previous study by the NICHD Maternal Fetal Medicine Units Network that used a combination of ampicillin and erythromycin. The actual regimen was 2 days of IV ampicillin erythromycin and then followed by 5 days of oral amoxicillin erythromycin that showed not only a reduction in respiratory distress, and a reduction in necrotizing enterocolitis, but also an increase in the time to deliver. And the idea that there's an increase in the latency to delivery is the reason why sometimes ACOG and other organizations call this use of antibiotics latency antibiotics. My particular bias is that increasing the latency doesn't do you any good unless it improves the neonatal outcome, and that really these reductions in neonatal morbidity are more important than the increase in latency. Latency is not a benefit. it's a cost unless there's some improvement in the actual outcome. So it's become standard of care now to give prophylactic antibiotics, and usually some combination resembling ampicillin and azithromycin. Several studies have looked at the idea that maybe rather than using erythromycin, which is generally poorly tolerated, causes a lot of nausea and vomiting, that maybe you could substitute azithromycin instead. And a meta-analysis was published last year comparing 5 randomized trials of azithromycin versus erythromycin, found that similar latency and less chorioamnionitis with the use of azithromycin. And so it is reasonable to substitute azithro instead of erythromycin. A study published this year suggested that maybe you do better to extend the treatment rather than just continuing the treatment for 7 days, that you could go for longer. This was an open label trial of cefazolin plus clarithromycin, so I'm not sure where they got that regimen from, but that's what they used. And the randomization was a 7-day treatment versus continuing the antibiotics until the patient delivered. There was relatively no difference in serious outcomes and similar latency in the 2 groups, but there was less respiratory distress in those groups that were randomized to prolonged treatment. The problem with this trial is that most of the patients in both groups delivered within 7 days. So although the idea was to randomize the patients to a prolonged course of treatment, most of the patients in the prolonged treatment group didn't even get prolonged treatment. So why there's a difference in the outcomes, it's not really terribly clear. And I think this is not standard at this point. Remember that one of the principles of antibiotic stewardship is to keep the duration to a minimum as long as it's effective. And so the question is the prolonged duration any more effective than the short duration? And at this point, there's not sufficient evidence to recommend a longer course than 7 days. Talk a little bit about group B strep, actually a fair amount. So group B strep, we all kind of know this, it's been hammered into us for the last 30 years. There are several indications for giving antibiotic prophylaxis for mothers who are group B strep carriers and other indications. So one is if they had a previous newborn with invasive group B strep disease. If in the current pregnancy, they've had GBS bacteriuria at any gestational age, and if they have a positive culture, so screening cultures at about 36 weeks of gestation is the current standard of care. So all pregnant moms are supposed to be getting cultured at around 36 weeks. And if they have a positive culture, then they get prophylaxis during labor. So moms that have a C-section without labor or without ruptured membranes don't necessarily have to get group B strep prophylaxis, but they still should get some prophylactic antibiotic. So usually cefazolin, unless other reasons. So one concept of antibiotic stewardship is what to do with patients with unknown group B strep status. Group B strep status, if it's unknown, is not by itself a risk factor for neonatal group B strep sepsis. There needs to be some other risk factor, either preterm birth or prolonged rupture of membranes, or maternal fever in labor, or known group B strep positive in a prior pregnancy, because those patients are oftentimes recurrent carriers. But you don't need to give antibiotics just because you don't know the group B strep status. If the culture was not done, or you can't find the result, or whatever, it's not necessarily an automatic indication to prophylax those patients. There needs to be one of these other risk factors developing. So the standard regimen, if the patient is not allergic to penicillin, is to give them IV penicillin. And the ACOG says you can also use ampicillin, but the preferred regimen is penicillin. And it's clear that the spectrum of penicillin G is narrower than the spectrum of ampicillin, and the concept of antibiotic stewardship is to use the lowest spectrum, the narrowest spectrum antibiotic that's effective. And penicillin G, GBS, is still 100% sensitive to Pen G, and so this is the standard recommended regimen. What to do with patients who present in preterm labor? So they haven't had their culture yet, so they're before 36 weeks of gestation. What ACOG recommends is as soon as they present in preterm labor or suspected preterm labor, obtain the Group B strep culture screening. And what ACOG says is start the antibiotic for prophylaxis and then decide, is the patient entering true preterm labor or not. So remember that over 80% of patients who present with suspected preterm labor turn out not to be in labor. And so they say recommend decreased GBS prophylaxis. What I would suggest is better stewardship is not to start the prophylaxis in the first place until you determine that the patient is in true preterm labor, that is demonstrating progressive cervical change, in which case, until you know the Group B strep status, you continue the antibiotic. If the patient's not in preterm labor, you can wait and see what the culture result says, and if it's positive and they're in labor, then give them prophylaxis at the onset of labor. And if it's negative, then don't give prophylaxis and then just treat them at term whenever they go into real labor, treat them at that time. For preterm ruptured membranes, it's the same kind of thing, is that these patients are going to get some antibiotic, whether they're in labor or not, either what ACOG calls latency antibiotics, that regimen that I showed you before, which is ampicillin, azithromycin. If the patient's in labor, you continue the antibiotics. If they're not in labor, then you treat according to the Group B strep culture results. And remember, these patients are going to get antibiotics anyways for up to 7 days if they have ruptured membranes. So by that time, you have plenty of time back to get your culture result, and then you can decide whether to use strep prophylaxis in addition to that antibiotic prophylactic regimen for ruptured membranes. So penicillin allergy is an important concept. Over 10% of patients report some penicillin allergy because ampicillin, penicillin, Group B strep remains 100% sensitive to these medicines as well as to vancomycin. About 40 or 50% resistance to clindamycin and erythromycin. Tetracycline is even off the table. It's almost all resistant. So this erythromycin and clindamycin resistance has been relatively constant since the early 2000s and not really changing. Over 50% resistance to erythromycin. Clindamycin resistance is hovering in the 40% range. So if patients present with penicillin allergy, you're going to be using a second-line agent. And whether it's going to be clindamycin or something else, it's important. But we'll talk about that in a minute. But it's important to recognize that not all patients that report a penicillin allergy are really reporting an allergy, and some of them have different levels of risk associated with them. First of all, many of the patients are reporting non-allergic type symptoms, like headache, or they got a yeast infection, or they got nauseated when they took it, or whatever. So this is not an allergy symptom at all, and that's an incredibly low risk situation. Some patients report that they got a rash, but they didn't have any systemic symptoms and didn't have any itching. So that's a low risk situation. Even if they had itching without a rash, that's a low risk situation. If they report some history or they have a family history, but they have no recollection of any symptoms or whatever, that's generally low risk. Patients that are a higher risk are those that have respiratory symptoms, angioedema, anaphylaxis, hives, urticaria, pruritic rash. These are higher risk situations, or multiple penicillin allergies, et cetera. And it's important to categorize the risk level of a penicillin allergy, because how we deal with Group B strep prophylaxis depends on that risk level. If they're at low risk in any of those categories that I showed you, the recommended strategy for Group B strep prophylaxis is to give them 2 grams of cefazolin IV load, followed by 1 gram every 8 hours. So cefazolin is over 90% sensitive to Group B strep. So it's a fairly effective medication for Group B strep prophylaxis. If they have a high risk allergy, then you should, at the time of obtaining the culture for Group B strep, find out, is the patient clindamycin, you should request sensitivities with your Group B strep culture. So it's important every time you're obtaining a Group B strep culture to take that moment when you're collecting that swab to review the patient's penicillin allergy history. And if they have a high-risk penicillin allergy, then you request a clindamycin sensitivity when you send the culture. And the reason for this is that if they're clindamycin susceptible, and around 60% will be susceptible, then the treatment for these patients in labor is clindamycin. But if they're resistant, then you use vancomycin. And you don't want to be using vancomycin on everybody that reports a penicillin allergy, because remember that the development of vancomycin resistant MRSA is important. We want to minimize the use of vancomycin to prevent resistance from developing for MRSA infections. So this is the ACOG recommendation for that. And if we can't categorize their risk, then the recommendation is allergy testing for those patients who report a penicillin allergy. And what I would argue is that maybe anyone with these high-risk infections, short of anaphylaxis or respiratory symptoms, probably should get penicillin allergy testing. So this is a patient information page that came from JAMA a few years back, and the little infogram here is shown in large. You know, what they recommend is that they say that you should get penicillin allergy testing even during pregnancy on patients who report rash or hives. So this is a moderate risk situation. You don't do it for patients with severe cutaneous adverse reactions like Stevens-Johnson syndrome or anaphylaxis, but these patients can get tested during pregnancy. It's safe during pregnancy, doesn't cause any harm. They also recommend that if the patient really doesn't have allergic type symptoms, they don't need to be tested at all, and you can actually just use penicillin. ACOG recommended cefazolin for those patients for group B strep prophylaxis, but you can use penicillin according to this guideline. So allergy testing, when patients get referred for allergy testing, several studies have shown that over 90% of patients who report penicillin allergy that get sent for skin testing, over 90% of them turn out to be negative. That is, most patients who report penicillin allergy do not have documented penicillin allergy. And this is really important not only for group B strep prophylaxis, but also for lifelong treatment for these patients. It really opens up the availability of first-line antibiotic treatments for a variety of infections if you can use penicillins and for patients, even though they report this allergy. I want to talk a little bit about antibiotic stewardship and in ambulatory practice. Here, the CDC has another checklist for antibiotic stewardship. It's a much shorter checklist for patients, for physicians who are in a private practice. One is, can you just, 4 yes or no questions. Can you demonstrate that you're dedicated to appropriate antibiotic prophylaxis patterns? Have you implemented at least one practice to improve your prescribing? Do you monitor at least one aspect of your prescribing? And do you provide education to patients regarding antibiotic use? So it's a much simpler checklist to do, and I would recommend that each practice consider looking at adopting something so that they can meet these core elements. In terms of some of the common scenarios that we see in outpatient practice, one is a high-risk situation that CDC was very concerned about. They considered an urgent scenario was the drug-resistant gonorrhea. And you can see that over the years, almost all the agents that have been tried eventually develop resistance. This one is tetracyclines. It used to be the first-line agent. Resistance developed. Ciprofloxacin resistance developed. Penicillin's resistance has developed. And so the current recommendation actually is azithromycin resistance is developing in recent years. The current recommendation is to treat gonorrhea with ceftriaxone, 500 milligrams, a single dose, and you can see that resistance has not yet developed to ceftriaxone, the purple diamonds in here. But I would recommend that you always consult the CDC guidelines regarding the current regimen, because this may likely change. This is from 2019, and it may likely change over the next few years. Bacterial vaginosis was something in the 1980s and 1990s. There was a variety of reports that showed that bacterial vaginosis was associated with preterm birth. And so it became commonplace to do studies to evaluate whether treatment to eradicate bacterial vaginosis would reduce the risk of preterm birth. So by 2020, there had been 6 randomized trials that were studied in this meta-analysis. And you can see that overall, no reduction in the rate of preterm birth by the treatment of bacterial vaginosis with either oral metronidazole, which is the OM here, or vaginal clindamycin, which is VC here, no reduction in preterm birth by the use of antibiotics to eradicate BV. When you actually look at the rate of preterm birth in the control groups in these populations, ranging from about 6% to 15% or so, it's actually not a huge increased risk of preterm birth anyways in the patients with bacterial vaginosis. So maybe the problem was overblown in the first place. The important thing is that you don't need to try to eradicate bacterial vaginosis if your goal is to try to prevent preterm birth. If the patient is bothered by symptoms, that may be a reason to treat it. But not with the idea in mind of reducing preterm birth. It's the idea of minimizing symptoms. So asymptomatic BV certainly does not need to be treated. Concern has been raised by the study from last year that the overall, if you look at patients who received antibiotics during labor, there's a consistent increased risk in preterm birth, adjusted for all these other confounding factors that you can find, that basically every antibiotic class studied has a higher risk of preterm birth if the mother received antibiotics compared to mothers that didn't receive antibiotics. So don't want to be giving antibiotics willy-nilly. You want to be giving it if there's a specific indication. One of the more common indications has to do with bacteria in the urinary tract. It's standard of care to do some assessment for urinary infection at the first prenatal visit, and some patients turn out, probably 10 to 15% of patients turn out to have asymptomatic bacteriuria. That is bacteria in the urine, even though they don't have symptoms. And this is associated with a relatively high risk without antibiotic treatment, over 15% rate of pyelonephritis, 15% rate of preterm birth, and 2/3 of these patients persist with having bacteriuria all the way to delivery. All of these are reduced by treatment. With low certainty evidence in this meta-analysis, but the use of antibiotic treatment to eradicate asymptomatic bacteriuria is currently recommended. But to do it in a way that's consistent with antibiotic stewardship, you should only treat if it's really a bacteriuria and not just a skin contaminant. So there needs to be a monoculture of greater than 10 to the 5th. Otherwise, it's just considered skin contamination and you don't need to treat it. That you should target the antibiotic to the documented sensitivities. That is, wait until you have sensitivities. These are asymptomatic patients. There's no urgency to treat it right away. The optimum duration of treatment is not really known at this point, although most experts say 5 to 7 days, and most experts recommend a test of cure. And if it's persistent, there's a question of whether you should just retreat versus put the patient on some regimen to suppress bacteriuria. Acute UTI is another situation where antibiotics are clearly indicated. So these are patients who have symptoms like dysuria or pyuria or urgency, frequency. So the antibiotic stewardship recommends that you actually shouldn't treat the antibiotics until you actually have a culture and sensitivity. So these are patients with symptoms. They're bothered by the presence of the infection, but don't just treat the symptoms with antibiotics. You can treat the symptoms with pyridium, which actually is a urinary tract anesthetic and leads to substantial symptom improvement, and wait to use antibiotics until you have a culture back that actually shows that those symptoms are due to infection. This will help to minimize resistant strains. It's not known exactly how long you need to treat for. Most experts say 5 to 7 days, and most experts recommend a test of cure. So along with the concept of antibiotic stewardship, more recently we've seen the suggestion of the concept of a diagnostic stewardship, which is the process of modifying your ordering, performing, or reporting of diagnostic tests to improve diagnosis and treatment, primarily related to infections, but also you can expand this concept to other conditions, that if you are judicious in your use of diagnostic testing, then you may not be overutilizing the system. And diagnostic stewardship as it applies to urine cultures would be, one, the concept that we shouldn't do a culture just because of non-specific symptoms. such as a mother with isolated fever and no urinary tract symptoms or fatigue or other non-specific complaints. One of the places where we see urine cultures still obtained a lot is patients with preterm contractions or suspected preterm labor. And studies show that these patients actually have a relatively low risk, less than 10% in most studies, actually have bacteriuria, let alone UTI. And so maybe you can avoid doing urine cultures in those patients unless they have UTI symptoms. So they recommend if you have a urinalysis that shows white cells, of course, then you order urine culture. So, or starting with a UA and with a reflex to culture may be a reasonable approach, and don't order based on just the appearance or the smell of the urine. That you should avoid catheter specimens unless absolutely necessary, and don't collect from the catheter bag. This review article suggested don't treat asymptomatic bacteriuria and do not order a test of cure. I put those in light gray here because I think that this review was not specifically related to pregnancy, and there's plenty of evidence that treating asymptomatic bacteriuria in pregnant people leads to beneficial outcomes. So I think that it's still reasonable to treat asymptomatic bacteriuria and to do the test of cure in pregnant patients. The reporting cascade concept is that the laboratory, rather than reporting all the sensitivities of an organism, should only report sensitivities for the narrow spectrum antibiotics, and they may run sensitivities on the broad spectrum antibiotics, but only if the patient has an allergy or other reason why they can't get the narrow spectrum. In other words, for example, if you have an E. coli, first report the sensitivity to cephalosporin, and if the patient is resistant, is allergic to cephalosporin or can't get it for some reason, then the clinician can call the lab and say, hey, did you also test it for penicillin class drugs or other drugs? Because I can't use cephalosporins. Did you test it for nitrofurantoin, et cetera? And that the laboratory can actually nudge the patients to nudge the physicians by putting a note that unless the patient has symptoms, don't treat or something like that. So that's the new concept of diagnostic stewardship in concert with antibiotic stewardship. So that's a lot of information. Thank you for your time and attention today, and we'll open up for questions if you have them.
So we do have a few questions. The first one is, what is your recommendation on ESBL positive mom with UTI or any other skin infection? The question is, do we need a culture to show their complications if the baby is sick? Switch to appropriate antibiotics.
So ESBL infections, yes, you would want to switch to appropriate antibiotics based on the sensitivity if that's what your report shows. And I don't know how you'd know it was an ESBL infection unless you had the sensitivities.
Right. So same person, different question. When you have Preterm mom on latency antibiotics, any evidence that probiotics are useful?
I'm not aware of any studies that have actually looked at the use of probiotics in addition to the antibiotic prophylaxis for patients with PROM or really any pregnancy condition. I'm not saying there isn't such a study. I just don't know it if there is.
Yeah, this is in the context of the neonate. One of the things is that obviously probiotics are the bacteria are commonly killed by the antibiotics that we use, and so there's clear evidence antibiotics change the microbiome, as you had discussed earlier. In babies, I would assume that this would be similar. You might not be helping much because the antibiotics are not allowing the probiotics to help you.
Yeah, and I know in the neonatal literature there's a wide variation in the types and the exact organisms that you pick for the probiotic regimen, and their efficacy probably depends a lot on the exact regimen. So I don't think you can really speak of probiotics as a class and so kind of say, well, probiotics are good. It would probably be specific agents in specific scenarios, you know.
Right.
That's at least my understanding of the neo literature, which is not really my specialty. But it's a good question. We don't generally run into huge problems with the maternal flora changing a lot, except for the selection of yeast. And so we get a lot of yeast vaginitis, and it tends to be worse the longer the course of treatment is. And yeah, I just don't know of any studies that people looked at trying to either prevent that or treat that with probiotics.
Okay. A question from Dr. Perez, a neonatologist. What would be the mechanism of RDS reduction when infants are exposed to antibiotics prenatally when mom has PPROM?
I would speculate that a certain percentage of newborns with RDS, what you're actually seeing is pneumonia, that some of it is infection related as opposed to just classic surfactant deficiency. And that's probably what drives it. That's speculative. I don't have benefit of data to support that idea.
Yeah, and he raised the question: is it be related to change in surfactant? But in the activation of surfactant would actually make the RDS worse. So, so next question is: this was a great talk. There's a lot of content here for clinicians. Have you seen any promising efforts for clinical decision support software that makes it easier to do the right thing? That's what we all want, right?
Yeah. You know, I'm for the SMFM Quality and Safety Committee participating in a team that's writing a review of clinical decision support and how it impacts perinatal care. And we divvied it all up between about 6 of us that each took a section. And I don't think anyone had a section on clinical decision support for antibiotic selection. And it's not something that any of us was aware of as a topic for discussion. You know, now with AI exploding, it's really impossible to keep up with it. And so there's undoubtedly somebody's looking at it. I'm not familiar with that literature at all.
Okay. Many midwives will treat term mothers with antibiotics due to prolonged ruptured membranes, even though they're group B strep negative. What are your feelings on the effects on the neonatal gut microbiome?
Well, the evidence on the neonatal gut microbiome is that it will alter the gut microbiome. Whether that's going to be harmful for that specific scenario, I don't really know. I mean, there's conflicting data there. There's, on the one hand, you have the microbiome change, but on the other hand, you have the general observation that antibiotic prophylaxis in labor for whatever indication is associated with decreased neck. So I think you'd need a lot of data to answer that relative question of short-term benefit versus potential for long-term harm. And I don't think that data exists right now.
So the next question is there any ongoing research on changing latency antibiotic coverage to include gram-negative organisms?
I'm not aware of anyone doing those studies. There may be studies being done, but the best evidence right now is that combination of erythromycin or azithromycin and psyllin type drug, amoxicillin or ampicillin. So you generally get good results with that combination, and so the azithromycin gives you reasonable coverage for gram negatives, and I think that's why that combination works well.
Okay. More of a comment is: could the reduction in RDS be related to increased latency period? because the latency period was increased, what, about 5 days or something like that. But they weren't any where that they would have been a little bit more mature. So that seems like a reasonable hypothesis.
Yeah, you'd have to have access to the actual data to sort that out and do a multivariate analysis. I'm not sure that 5 days is enough of a increase in gestational age to explain the reduction in RDS seen in that trial. Certainly, it would help some, but I'm not sure that's all the effect.
Okay. Can you shed a little bit more light on the ampicillin gentamicin? I'm sorry, that's not the next question. A couple more questions came in on me. I think there's always this confusion around NEC and antibiotics and what you're using the antibiotics for. Can you kind of briefly go back? I know you went through this really well, but there was obviously one of the Oracle studies that showed NEC was increased due to prophylactic antibiotics, and then there was another one that says it was decreased. And the question here is, it was this person's impression that, generally speaking, prophylactic antibiotics were associated with an increased risk of NEC, but I think it's more related to what you're using the antibiotics for the indication and the antibiotic type, because it was amoxicillin and clavulanic acid, the problem, right?
Right. In that Oracle 1 study was the one that showed an increased risk of NEC, and it was either of the regimens that involved amoxicillin clavulanic acid. So either alone or in combination was the ones that had a higher rate of necrotizing enterocolitis. The erythromycin alone was not associated with that. None of the regimens were associated with increased risk of NEC in the Oracle 2 trial, which was the ones with the intact membranes. And then I showed you that other meta-analysis that just kind of lumped everything all together, all indications, all use of antibiotics in labor was actually associated with decreased risk of neonatal NEC. So kind of a confusing quagmire of studies.
Right. But for sure, I think we would all agree, based on the Oracle studies, that you don't want to use amoxicillin and clavulanic acid. What I kind of got from listening to your notes, that the ampicillin and erythromycin seem to be a safer approach in the indication of I think it was PROM.
Yep, for ruptured membranes. Yep, that's the classical latency antibiotic regimen for ruptured membranes is erythromycin and ampicillin. And again, as you can substitute azithromycin instead of the erythritol.
And I think the overall sense of this is that antibiotics change your microbiome, and that changes what's there that can cause problems in the gut in general. But some antibiotic approaches in certain indications seem to be okay, and it doesn't seem to be as bad as other ones.
Right. And the general principle is, don't use it just because you think it's a good idea, because there's lots of good ideas that turn out to be bad ideas. We need actual evidence before you. These are positive treatments that we do. These are active steps that we take to treat these, to use this prophylaxis to treat the infection.
Okay, last question.
Sorry about my dog's got a delivery person at the front door.
All right, so last question. Given increasing resistance of E. coli to AMP and JET, and E. coli's large communication contribution to early onset sepsis and extremely preterm medicines, is there any evidence to start an empiric regimen that's broader than AMP and JET? I'll take that one, Andy, because that is a ongoing conversation. There was a very good kind of a debate of this issue at the Society of Pediatric Research this past spring, and Karen Pupolo basically said, still felt like, based on all the evidence that we have, that the Ampijet is still the safest regimen, with the caveat that a quick change, if a child is not improving or there is any evidence of gram-negative, especially E. coli, there was, we are going to have, because it didn't come down to a definitive answer, there was some discussion from David Birchfield that in his nursery, they're seeing more problems with H. flu, and that they're considering dosing as an alternative, as an empiric, but none of that has been established in prospective trials, and the recommendations now have not changed. We're going to have it discussed again at video in the February of this coming year. So it's an important question. That's an open discussion, but I don't think we have clear guidance via the infectious disease folks that we normally look to answer these questions. So Andy, as always, you do a great job and help us. There were two other questions that if kind of forward to you, or y'all can send in, but we're past time, so we'll stop there.
Yep.
And thank you again for your great presentation. I appreciate it.
Well, thank you for the opportunity, and thanks for some great questions, and thanks again. Bye-bye.
All right. Have a good one.